right, please give a warm welcome to Dr. Joanna Harper.
I wanted to thank everybody for having me today. I've been part of the foundation for quite some time, and we'll talk more about that here in just a little bit. But thank you all for staying through the wonderful weather we have out there. I know my weather in Minnesota is about the same right now, so I thank you all for braving it out with me. And we're going to have a lively talk about pain management. So first, we're going to start off with a video.
It's hard to know how to move forward once chronic pain enters your life. It helps to think of a person with chronic pain like a car with 4 flat tires. Our expectation is all we need is one medication or treatment that will take away the pain. But it only puts air in one of our tires. We still have 3 flat tires and cannot move forward. Perhaps the medication or treatment has provided 25 or 30% relief. Let's leave that there and ask ourselves what else we need to fill our other 3 tires so that we can resume our life's journey. For each person, the necessary combination of therapies and interventions will be different based on individual need. Unlike traditional medicine, where the patient is passive, living a full life with pain requires that we become active participants. We need to work with our healthcare providers to find out what we need to fill up our other 3 tires. Biofeedback, physical therapy, counseling, pacing, nutritional guidance, a support group, and a host of medical treatments are a few ways to fill up our tires. Once we have all 4 tires filled, it's our responsibility to maintain our car. We wouldn't take it back to the dealer and ask them to fill it up with gas or wash our windshield. That's our responsibility. If something goes wrong with the car, we take it in for a checkup. It's the same with our wellness. You see, pain management is much more than one simple treatment. It takes a team effort, with the person with pain taking an active role to live a full life in spite of chronic pain.
Okay, so that kind of sets the stage for the talk today. And if you've looked through the slides, I will tell you my initial thought was, holy cow, what just happened? There are a lot of slides there, I know. It is mainly used as a reference. I'm going to touch on a lot of them. Most of them I will touch on today, but I will not go in extreme detail. So don't be surprised that it really is a thick packet. And I hope that you will use that as a reference for your providers. So, getting this thing started, maybe. There it is. Okay, so the talk today is about pain management and how to empower yourself to rely not on just opioids, but not to rely on any one thing in particular, and how to empower yourself to take a more active role in your pain management. So the objectives today, we just saw the video on the car analogy. That's going to be really important here. And understanding that it's complex and that we're going to have to use a bunch of different tools. And we're going to go through opioid pain medications because that's always a question, talk about other medications for pain, as well as complementary treatment options and outside of the box options. So the goal really is to develop a toolbox that you can use for pain management. And as your pain changes or as your body changes, you're going to need to use different tools at different times. So the more you have different tools, you know how to use them, you know what you have, you know what you can take out at different times, and then that way you have more control over your pain. So a little bit about me. I've been told that I don't show enough vulnerability in life, which doesn't surprise me. I am too a Scleroderma patient. I have scleroderma and lupus, and I've had it for more than 20 years. So I went through pharmacy school in the eyes of a scleroderma patient. So I'm taking all of the information that I know from both schooling and everything else I do outside of school to bring it to you both as a patient and as a provider. What I do currently is I'm a chronic pain management pharmacist, so I see patients inside doctor's offices, just like you would see your physician. You would see me instead, and we would go over pain management, medications, options, as well as everything we're going to talk about today. Other things I've done, all sorts of consulting. I've done pain management all across the country in different settings. So really what it comes down to is, you know, I'm a patient just like you guys. Everything I'm going to talk about today is a lot of what I've tried too, and I'll tell you where my difficulties are. So really, it's all about just communicating and trying to come up with what plan works for you. And you will see my little miracle baby there through the years for every conference. If you guys come to the July conference, you will get to see her. That's a little plug for the July conference. I will be talking about medical cannabis at that talk, so that will be a full hour. So I will not be able to talk about medical cannabis in extreme detail today, but we will touch on it. So ultimately speaking, I don't have any disclosures. I don't work for any type of drug company. I don't sell anything. I sell my knowledge, and that's about it. So really my goal is helping you guys out and to figure out what's going to work for you. And I will be talking about off-label uses. We just have to kind of accept that 90% of pain management is off-label. So outside of the box is all about that. So the patient comments that I get all the time is, why is the opioid epidemic affecting me? All my doctors think that I'm drug seeking. Pain medications are the only things that help. Pain has the power over me. And I never knew I could feel this good with taking so little medication. And that's after we're done with them through an interdisciplinary plan. So when we talk about pain, pain really is an unpleasant sensory and emotional experience. Whether that's perceived or whether that's real, it's still there regardless. So the brain makes up this story based on our past experiences, and we can determine how we take that. It can be emotional, it can be psychospiritual. So there's all different forms of pain. The problem is our body takes all of that energy and forces it into one area. And it could be a couple of different areas, but the nervous system is always adapting. It's always changing. So really what this stands for us is it can adapt in the wrong way, but it can adapt in the right way also. So there's always hope. If you know nothing else about me from today, there's always hope. So the other thing with pain, the goal of pain management really is, what is the cause of the pain? And that's always half the battle. So with scleroderma, there's a lot of different reasons for pain, whether it's the skin itself, whether it's inflammatory cytokines, whether it's muscular issues. There's all sorts of different reasons for pain. So the goal really is to figure out what that cause is, and then to take into account that there are other causes also. So anxiety and depression can worsen pain, and pain worsens anxiety and depression. So it's a vicious cycle. Any type of social pressures, any type of nausea, vomiting, gas, like the other doctor was talking about earlier today, you know, as far as GI pain, there's a lot of reasons for that too. So abdominal pain is all over the map with what the causes could be. So it's always looking back at that and trying to figure out what that cause is and to treat it effectively. So like the video said, pain is like a car with 4 flat tires. You can pump up one tire with medication. What do you do for the other 3 tires? In order to live a full life with pain, you have to take an active role in that, and each person has different needs associated with that. So you have to develop that toolbox for yourself. Learn the various tools, determine what they do and how they work, assess who you want on your team. So you can have anybody you want in the car. So you tell us who you want in the car, and there's all sorts of specialists we'll talk about here in a minute. And the goal really is you drive your car. We can't drive your car for you. We don't want pain driving your car, and that's what happens most of the time and I know from experience, pain drove my car for many years. So now, after many years of work, pain is now in the trunk, but we're still going to drive around with that thing back there. So, you know, it's coming up with different ideas, what works for you, and it really is a team effort. It will never be, you know, any one tool that will be the magic. I'd love to have a magic wand and I'd give it to all of you. We just don't have that. We have a lot of ideas on what can help, but no magic wands. So really, successful treatment is, coming up with a plan, figuring out the goals that you want, any functional goals, how to reach those functional goals, and how to live a good quality of life. So ultimately speaking, I am a person that tells you how it is, pros and cons. I try to be as politically correct as humanly possible. I am not always that successful. So I'm going to be real today, and hopefully y'all can be real with me as well. So some of the misconceptions for pain. It's not all in your head. You don't just have to live with it. It's not a natural part of living. The doctor does not know your pain best, so on and so forth. So the goal really is to have you and your doctors see it as you as a whole person. And that's my goal today, is to look at the body as a whole and how to treat it effectively. Everything we talk about today will help with also anxiety. It'll help with depression. So these are just tools of life that just happen to help with pain too in the meantime. And none of your providers are ever going to agree. Everybody has an opinion. And I can't say my opinion is exactly right, but what I'm saying is take some pieces of the information here and discuss it with your providers. By no means am I trying to say that I can overrule one of your providers, okay? This is means for having a conversation with them. So the importance of pain treatment, I lost it, okay. Poorly managed pain, interestingly enough, so on one end of the spectrum, it's treating pain too much, which we'll talk about. And then the other part is treating it ineffectively or poorly managed pain. So poorly managed pain, for us, that can weaken our immune system and aggravate other health conditions causing depression and anxiety. So not to mention the social implications, inability to have a good quality of life, perform daily tasks, so on and so forth. So treating pain is absolutely important. We just want to figure out how to do that in the best way possible. So one thing I want you to see here is these are different scans of people with no pain. 0 pain on these people, okay? 80% of these people had disc degeneration with no pain. So what I'm saying here is pain, whatever name they give it, does not equal pain. So disc degeneration is one of those words that we use that scares people, and it makes us think as patients that we're doomed, it's over, we may as well just hang it up, I'm going to be in pain the rest of my life. Other words that they use include cartilage damage. They use stenosis. How many of you have heard the word stenosis? Okay? It doesn't always equal pain, but it's scary. And so that's called the nocebo effect. You guys have heard of the placebo effect. So you get something that does nothing. This is you get something and it does bad stuff. So we don't want that either. So when you see those x-rays and you see other things on scans, it doesn't necessarily mean, aha, that one point is the reason for my pain. It is much more complex than that. So don't take some of the words that we say to heart when it comes to long-term effects. So we like to say fussy joints, or the nerves live in small houses for stenosis. So I'd rather hear my nerves live in a small house and I'd rather upgrade the house than think about stenosis that, there is no solution to. So opioid pain medications, I will run through the quick CDC guidelines real quick. Long story short, CDC came out with these guidelines. Guidelines said a certain amount of morphine equivalency is bad. So if you're on high dose opioids, that is bad. But the problem with these particular plans is they weren't meant to be for all of pain management. That was meant for primary care provider to send them to a pain care specialist. That didn't happen. And so now I will say with hope, the CDC guidelines are swinging back the other direction and saying, wait, we didn't mean for that to be a guidelines. Okay, number one, even though it says guidelines in the title, we're not talking about that. But in all reality, they're coming back to say, hey, let's look at the patient as an individual. Is this the right drug at the right dose for this patient? Holy cow, it's about time. Same thing I've been talking about the whole time, but this pendulum keeps swinging. So unfortunately, the doctors chase this pendulum because they're threatened with their license, which I can respect as far as they don't want to lose their livelihood either. But really what it comes down to is what's best for the patient. So it is coming back slowly but surely, but the only thing that it means for us as patients right now is, okay, opioids don't treat pain. Let me say that again. Opioids don't treat pain. I'm not pro-opioid. I'm not anti-opioid. I am pro-patient. Opioids are good short-term, but if we do high doses for a long period of time, they decrease our immune system, they increase weight gain, they increase disability, but more importantly, they change 6 vital hormones that are necessary for life. Sometimes I can't get those hormones to regulate even once you're off opioids. So there's a lot of downhill cascade issues that are happening, and that's a bigger issue here. So that's what I need you guys to understand, is that they are a good tool. They're a tool that we have, but they're not treating anything, and our body says, hey, wait, we need to feel pain to survive. I'm going to upregulate the amount of receptors that I have, and now you have to deal with the more receptors that I have, and now the drugs don't work as well. So nothing that we as patients have done wrong, but really what it comes down to is its physiological response to a drug that's not necessarily natural. We need to feel pain to survive. So how do we work around that, and how do we use opioids, or not use opioids in the treatment of pain, but how do we use them more responsibly? That's really my moral of the story. So dependence and addiction with opioids, I'm not necessarily worried about that. If they are used appropriately for pain management, addiction is low. But there is always physical dependence, as you will see with medical marijuana as well. So physical dependence is a physiological change in your body to a foreign substance. You're going to have withdrawals if you get off of it. That is not addiction. That's my only point for that slide. Okay, so the role of the pharmacist. Yeah, what do I do? So it's the difference of each medication, how each medication in each class, so each class has multiple medications, how does each medication differ? So we look at, is that the right drug for the right patient? Are there drug-drug interactions? Is that drug going to make the other symptoms that you have worse with scleroderma? Is there other medication review that needs to happen? So over-the-counters, herbals, OTCs. So we take all of that into consideration. We look at what are barriers to care, and we look at collaborative agreement. So that allows me to prescribe with approval of a physician, but it doesn't necessarily need a signature, which is kind of nice. And then we prescribe naloxone when it's appropriate with high-dose opioids. So that's the rescue drug that's necessary for an overdose. So I will run through medication options painfully fast. I'm only going to bring up what is most hot topic right now and what I think is most important to you as scleroderma patients. I say just say no to drugs here because I did not go to pharmacy school believing that medications were the answer. I went to pharmacy school because nobody could tell me what they did. I was a 12-year-old child and they're telling me to take this list of medications, and I kept telling them, is it going to make me any shorter? Because I'm not getting much shorter here, people. And they couldn't tell me. So I took my own route and decided, well, I'll figure it out then and be able to share it with everybody else. So that's not necessarily saying no drugs, but what I'm saying is let's not rely on them as our sole source of anything, because wellness is really what our goal is. Wellness and being proactive in our care is better than a reactive response with medications. And I'm not pro-medication or anti-medication, I'm pro-wellness. So when it comes to muscle pain, there's a lot of different medications. The big differences here that you can read later is there's a big difference between muscle spasticity and muscle spasms. So spasticity is when it basically tightens up and stays that way. Those drugs on that side of the column are better for that. And then the ones on the right-hand side are for spasms. Some drugs work better for others, and doctors don't necessarily know the difference between these, which is why I have this chart here. But more importantly, what I think is important, here's all of the side effects that are important to you for different medications. So for spasticity, baclofen can cause significant dry mouth. Tizanidine can cause dry mouth as well. So these are all things that we need to know when we already have dry mouth. And then cyclobenzaprine, I don't know about you, but the dry mouth associated with that one for me was way more than I can even handle at even the smallest half tablet dose. So it's really what's important to you, but knowing what the possibilities are. So when it comes to muscle spasms or muscle spasticity, if that's one of your problems here, look down these medications, take this to your doctor, and discuss the pros and cons of each medication and the symptoms that you have. And then if you look on the muscle spasms, on the right-hand side there, it says for short-term use. So anything for muscle spasms. So we have people on cyclobenzaprine for years. That's not necessarily recommended. And the question is it really effective? Because really, the structure of cyclobenzaprine is really an antidepressant, but we market it as a muscle relaxer. So regardless, figuring out what that mechanism is and how it works to see if there's a better long-term option for you. And we will have time at the end for questions to go through it. But most importantly, there is a holy trinity of death. So we're talking about benzos and opioids. Okay, we know those two are bad. They stop the brainstem from telling your body that you need to breathe. Okay, what dose? I don't know. Nobody knows. Nobody can prove it to me. Higher doses for sure, you're increasing your risk of respiratory depression. But when you add metaxalone, soma at the bottom, or carisoprodol, or methocarbamol, those three are added to a benzo plus an opioid. Now we're talking about like the holy trinity of death. Probably not recommended because the sedation rate is so high, but we do it all the time. So that's really questioning, do we need all of these medications and what else can we do for these? So for nerve pain, the big medications of choice really are gabapentin and Lyrica. They're basically both cousins to each other. They decrease nerve-to-nerve communication. There are a lot of other medications on this list that we'll talk about too. So first line, like I said, was gabapentin because it's generic. Dosing as high as 4,800 milligrams is possible. Oftentimes they stop at 900 and say it didn't work. I'm going to tell you, most of the time the effective dose really is 2,400 milligrams a day. Okay? So it sounds like a lot, but that's what's needed for nerve pain. And then Lyrica was actually designed or tested for fibromyalgia in particular. And basically, long story short, they needed something else to continue their patent. It does have a better side effect profile, so if you can't tolerate one, oftentimes you can tolerate Lyrica with no problem. Biggest thing with Lyrica and with gabapentin is sedation, so that's why I dose it at night initially. But the big thing with Lyrica, and I have seen it, is peripheral edema, and for both of them, potential weight gain. So it increases or decreases your satiety, so it feels like you're always hungry. So other things to watch out for those drugs. And this is just a chart for your doctors. You don't have to go down on one to go up on the other. Just give them this chart if you're switching from gabapentin to Lyrica or Lyrica to gabapentin. And then other anticonvulsants you can use. This is just to let you know that I have literally 3 pages of small print drug options that we have for pain management. So this is just saying that if there's a seizure history or obesity, Topamax can be helpful. Or bipolar and seizure history, you have that whole list there that are also options for nerve pain as well. We do have topicals, lidocaine drug patch. So the 5% is prescription only. It is very expensive. They have the market on it. They can charge whatever they want to charge. I'll tell you, the 4% over the counter, 95% of my patients can't feel the difference. So, and it's, a tenth of the cost. So I recommend the 4%. The lidocaine cream is also another option that can be a prescription item or an over-the-counter. The only way the lidocaine patches are covered, the 5%, is usually for post-herpetic neuralgia or after the zoster, shingles, or diabetic neuropathy, which most of us would not necessarily have on its own. And then one topical that I think is really nice, that's outside of the box, is ketamine and lidocaine. That combination, ketamine is an NMDA antagonist, and we'll talk about that, but it works in a completely different way. This can be made at a compounded pharmacy. You can call around and get the best price, but oftentimes this can help decrease the nerve pain with very limited drug interactions and very limited systemic absorption. So I don't worry about side effects with that one, generally speaking. And then another option that's really helpful is BioFreeze. In the 360 can is preferred, but basically it's a counter irritant to give your brain something else to think about rather than the nerve pain. So it can be really helpful. There is Tiger Balm and Salon Pause. There's a whole bunch of others that we could talk about, but for the sake of time, we'll move on. Somebody wanted me to talk about Shingrix or the shingles vaccine. The only thing that to avoid chronic pain, because I do see those patients in my clinic. Basically, long story short, any patient over 50 years old, there has to be 2 doses, 2 to 6 months apart. It is in short supply. Make sure they have both doses and save one for you, because if not, you have to start over again. So that's my recommendation there.
Would you suggest the shingles shot for people that have Scleroderma?
It is a dead virus, so most of the times the recommendations is yes, it is recommended. But I would talk to your doctor to make sure for you in particular. Okay. It depends on disease activity or how active your scleroderma is as well. And then antidepressants. So another mechanism that's really important is norepinephrine. And norepinephrine is one of those neurotransmitters that we find is very active in centralized pain or any type of chronic pain over time. So if we can use a medication that has norepinephrine activity, we can decrease the central nervous system and bring it down a little bit. So this is usually for those people who have pain and it hurts for people to touch you. So like that wasn't really a spot for your pain, but it hurts just at the touch, even if it's not the source of your pain. So that means that you're usually either really sensitive to pain, you've had chronic pain for a long time, and that's just how your body adapts. It gets really sensitive to pain. So this is a way to help bring that central nervous system back down so that your body doesn't overreact to pain. So with the central nervous system, oftentimes, instead of a bike bell, it is now this 4-alarm fire when your brain really should be saying it's a bike bell. And so it helps us bring it back down to what a bike bell is versus a 4-alarm fire. So the biggest drug for that one is duloxetine or Cymbalta. And I will tell you that does have dry mouth possible with it, as well as nausea, but the nausea does go away with some time. And I recommend starting at the 20 milligram dose for scleroderma patients for that reason. A lot of my patients have said that has been their savior. Now, if duloxetine doesn't work or Cymbalta, you kind of move down that cascade. They are in order of preference for me. Sleep is very important. Tricyclic antidepressants are often not nice for scleroderma patients because of the dry mouth. It is more vicious. Nortriptyline is better tolerated, but generally speaking, when you start getting into the hypnotics like Ambien and Belsomra, generally speaking, I don't necessarily recommend them because it changes your sleep structure. So the ones above that are actually more preferred if you can tolerate the side effects. But sleep is very important, but freaking out about sleep doesn't help anymore. So basically, just knowing that, you know, if you can try to get adequate sleep without stressing out about it, that's the goal. So this is just a list of serotonin syndrome. Anytime you start adding more drugs with serotonin, and the last 3 slides were those, this is a list of symptoms that if you add one drug, it usually happens right away. So it's like an agitation, heavy sweating. You just feel really odd, and it's more like an internal thing, like an agitation and a restlessness. That usually happens 2 to 8 hours after starting a serotonin drug that's new. So that means that you added one drug and it already had serotonin, and then you added another one. Some people, I can add 4 or 5 of these and there's no problem. Some people you add 2 and it sends them over the charts. Okay, so it's just something to watch out for because it's often missed in healthcare. Joint pain, so we have all the anti-inflammatories, COX-1 versus COX-2, and we'll talk about those. So COX-1 inhibitors, basically less pain because it's decreasing inflammation, but you have an increased risk of GI bleeding with COX-1. So ketorolac is the most COX-1, or Toradol. But if you go further up that scale, like indomethacin is the least COX-1, so less GI bleeding. But if you have an issue with GI bleeding, then the COX-2 medications would be more preferred for you. So COX-2s basically inhibits at a lower level. In the cascade, there was a few studies initially, if you all remember Vioxx and Bextra, they disappeared off the market. They found an increased risk of heart attacks. But if you look at the charts, there's COX-2 way over here. Celebrex or celecoxib is kind of in the middle. So then there was a study that had Celebrex against ibuprofen, and they had the same cardiovascular risk. So it's like that cardiovascular risk, yeah, we're going to monitor that with COX-2, but there's less chance of bleeding, so generally speaking, they are better tolerated, but absolutely with food with those. But more importantly, this chart shows you there are a lot of different options available. If the ones on the top of the chart work better for you, then kind of go along that scale to see if you can find a medication that works better. Then you have topicals. The diclofenac or Voltaren gel is very, very helpful when you can't take anti-inflammatories and you have joint pain, especially hand pain. If there is swelling involved, it generally is helpful for pain to decrease inflammation, and it's not systemically absorbed to any certain extent to have real big concerns about GI bleeding or kidney issues, so on and so forth, like you would with the anti-inflammatories. With allergies, right there, it just shows you different classes. If you're allergic, they're separated out into classes. So if you're allergic to one, you might be allergic to one in the class, so I'd avoid the whole class, but you can move around between the other classes. So we talked about kidney problems, high blood pressure is an issue, any type of bleeding, and stomach ulcers are all things that you're going to watch out for, and you have to take them with food. Sometimes they will alleviate the concern for GI bleeding with a proton pump inhibitor, which most of us are on anyways. Okay, so stopping anti-inflammatories, cool chart to give your provider based from a pharmacist that basically says this is exactly how this drug works. So for example, naproxen, you need 4 days off of it prior to surgery, and ibuprofen, you only need 1 day. I would still follow the advice of your surgeon because they will choose whether to cut on you or not. But you can have an argument if you really feel like you need it. Tylenol, max dose is 4 grams per day, and that's 8 extra strength. And I'm telling you, guaranteed, anything after that is causing liver damage. 1 cell at a time, and you may not notice for a long time, but I will tell you, personal experience, my grandmother died of Tylenol overdose liver failure. Okay, 15 years worth. Okay, so 3 grams for the elderly. Or anybody with liver dysfunction, and that includes anything with Tylenol in it, sleep aids, cold medicines, etc. The elephant in the room, we talked about the CDC guidelines very briefly. There are becoming more and more restrictions. Like I said, we avoid them with benzodiazepines, but really what it comes down to is the insurances are telling us we can't prescribe them. The DEA is telling the doctors they can't prescribe them. Just a lot of restrictions, a lot of hoops to jump through. And like I said, we're hoping that's getting better. And I've fought for the right to continue to recommend or loosely on record, I am not prescribing these drugs since the video is running. But making the recommendations of opioids. So I wanted to ensure that we still have opioids available for when we need them and for those patients who need them. So all we have to say is that we're using them appropriately and we are using all of the other alternatives that we're going to talk about. So I'm not going to run through the opioids in detail, but we talked about serotonin syndrome. Tramadol would be one of those drugs that you have to watch out for. It does work on serotonin as well as norepinephrine. Perfect drug for that reason. It does work on the opioid. It is still an opioid. If I could get that changed, I would. I'm just one person, and I'm telling you, they're a lot bigger than I am. But another option is tapentadol, or Nucenta is a newer one out that has just opioids and norepinephrine activity. So that tells me it works better for nerve pain, and actually quite effective. I'm not going to talk about methadone and buprenorphine today, except basically to say methadone has a lot of different mechanisms of action. Sometimes we are leaning more towards this for long-term use because there's not as much of a body adaptation to it, and it works on serotonin and norepinephrine and the NMDA antagonists. So there's a lot of different mechanisms, which is really nice. But doctors are scared to order this too because of the opioid epidemic. So I can say that this is not in favor right now, but there's a lot of good information there that we can talk about if you're interested. Buprenorphine is one that they're leaning more towards. So now the trend is working in the pain clinics is, oh, wait, you're on opioids. Here, try Suboxone. Suboxone is known for like heroin abuse, so on and so forth. It is effective for pain, so I will say that. But there is a morphine equivalency that's different. So it is a partial agonist antagonist, which basically means there's a max dose. So once you get over that max dose, it's not going to give you any more pain relief, no matter how many more you take. So number one. Number two, if you're taking a morphine equivalency of 30 milligrams or more, while you start this drug, you are going to have withdrawal because the buprenorphine blocks that receptor too. It hits it and blocks it, but it'll block the other drugs. So basically, long story short, it'll rip that opioid off that receptor and put the buprenorphine there, thus causing withdrawal. So that's something you got to be careful for if you switch from one drug to another. So oftentimes you have to be off the medication for more than about 7 days. And then when you go into surgery, just keep the buprenorphine patch on. The buprenorphine patch is used for pain, not addiction. And it does not require an addiction specialist to give it to you. A doctor can prescribe it just like an opioid. But long story short, keep it on you during the surgery or keep it off for a week. Don't take it off right before because that drug stays on that receptor for 3 days. And so 3 days later, you're going to be on a high dose of opioids because that's what it took to challenge it in the hospital. And then that buprenorphine is going to leave the receptors, and then you're going to have an overdose. Okay? So keep it straight if you're going to do that. Next one. This is my favorite one in the whole wide world. Low-dose naltrexone. How many of you have heard of it? Woo, woo. Okay. So low-dose naltrexone works in a lot of different ways. I'm going to go see if I can go back to the other screen here. Maybe not. There you go. Low-dose naltrexone can actually reduce inflammation in inflammatory conditions. So that includes fibromyalgia, and we do have studies for fibromyalgia. The problem is no drug company has this. Okay? Good deal, because they're not charging me $1,000 a pill. Bad deal, because then the insurance doesn't cover it. Okay? So it's a compounded product. So compounding pharmacies can do it. I cannot tell you the recipe because that is against pharmacy rules, but I will tell you it's easy to find. Seriously though, it is a very easy recipe that any compounding pharmacy can do. They crush up a 50 milligram tablet and they put it in 50 mils of liquid. Perfect. So 50 milligrams, 50, is used for opioid abuse and alcohol abuse. We've been using it that way for 50 years. Okay? That's not what I'm saying this is for. That works on the opioid antagonist, so opposite of the oxycodones or the hydrocodones. But in really low doses, it works on microglial cells, which are in between nerves. So you have a nerve here and a nerve here. And the microglial cells are in the middle. And you know, in medicine, if we didn't know what it was, it didn't exist and it doesn't do anything. Any doctors in the room? Okay. So these microglial cells produce inflammatory cytokines. So if you have chronic pain, I could solve all of your pain, the actual cause of your pain, and you're still going to feel pain because these microglial cells are telling you are. Because they're still producing that inflammatory cytokines to tell your body to produce more inflammation. So this is a way to reset those microglial cells. So really a cool, novel idea here. And we found that at 1 milligram is kind of the starting dose, okay, for this particular drug. And the good news is, because it's compounded and it's a liquid, you can change your dose. So I'll tell you, if 1 milligram is too much, and for some people it is, especially with autoimmune conditions, you can stop for 1 day and then go down to 0.5 milligram. Okay? So you can adjust the dose as you need it to be able to tolerate the drug. My only goal is to tolerate the drug. Bad things, the only thing that I would consider here, vivid dreams is a side effect, but it is also being treated, it's being used to treat PTSD. Okay? Another mechanism that it has is it's potentially an immune modulator, meaning that it may help stabilize the scleroderma. I am not saying that on record. I am saying this is new and promising and hopeful information. Okay? Talk to your doctors about it. There is information online, and all of the references are there at the bottom. Low Dose Science, and then there's the Low Dose Research Foundation as well. So if you guys need more information, just let me know, and I will send you what you need with the research documents as far as the studies that have been done. It does not interact with Cellcept or methotrexate or any of the other ones. The way I put it is it may help stabilize the immune system, so in hopes you might need less. But talk to your doctors. That's all I'm saying. So interestingly enough, with this one, the third mechanism that I think is really cool, it makes your body produce its own opioids. Yeah, how about that? I want my body to do it all on its own. So through all of those mechanisms, it is a promising drug. There's a lot of research being done right now, people trying to get more research out there. I am personally fighting the state of Minnesota Medicaid department to pay for it. My compounding pharmacy makes it for me for $30 a month for all of my patients. So, and they'll either make it capsule or liquid. So just call around and see what's the best price. The pill itself is 50 cents, people. I mean, come on, how bad can this be? So I'll get off my soapbox. The dose, really, my starting dose is 1 milligram or 0.5 milligram if you're really sensitive to medications. And it's only once a day. You increase by 1 milligram a week until you get to about 4.5 milligrams. Then you hang out at 4.5 for a month or two and see how you do. Now, if it does cause pain initially for the first couple of days, that is a side effect because your body's getting rid of that inflammation. That tells me it works, though. So it's bad but good. So cheap benefit there. But if it is too much, then you go down to 0.5 milligram, for instance. So there's a lot of different options with this particular drug. We're going to see a lot more come out about this. And I'm really hoping a drug company doesn't get to it before we do. Okay, other options. Here's all of the mechanisms, everything that I told you about, being used to treat all sorts of inflammatory conditions, autoimmune conditions, including Crohn's. There is some rumor about cancer, but again, it's rumor. And then we talked about NMDA antagonists. We talked about the ketamine cream. We talked about methadone too, that was in this, had this mechanism too. Ketamine is just not well absorbed orally, and so the dosing is not well defined yet, but it is an option if you've been on opioids and they're not working, or you've been through all of the other cascades. So we can talk more about ketamine if you want, but really the goal there is to show you that there are a lot of different options. So medical cannabis, the big elephant in the room here. So there are different cannabinoid receptors. And the goal here is to look at all the different receptors and how it works. So there's a big difference between CBD and THC. So CBD is more anti-inflammatory in nature. THC is more psychoactive, but it works better for nerve pain. There is some evidence out there that CBD alone works for anxiety, but CBD plus THC oftentimes has a synergistic effect to make 1 + 1 now equal 3 instead of 2. Each state is completely different as far as what the laws are, whether it's medical, whether it's long-term, or whether it's recreational. I will say, I have a long talk about this in July, like I had mentioned. I will just say, my concern is that it can be effective. We don't have enough data. So my concern as a pharmacist is, are we trading one epidemic for another? and that's where my concern lies in this. The CBD alone can be really helpful, and it does work on a different receptor, but we just don't have enough research to say what the long-term side effects might be. So I just say proceed with caution on these. There is CBD from hemp, which is a different plant. It's the genetics are a little bit different from marijuana. The CBD from hemp is perfectly legal as a dietary supplement. And then they did actually come up with a CBD product just recently through the FDA that's going through testing right now for seizures. But that's where we're getting a lot of our information on the safety data. So there are drug interactions. Just proceed with caution and make sure that you're looking at the drugs that you're currently on and monitoring for any side effects. So we'll just be brief on that one. Big side effects, though, that we're concerned about: impairment of memory. It can cause anxiety and nausea. And I will tell you, other patients have told me that THC does cause dry mouth pretty considerably. Okay, topicals, we talked about biofreeze. Another option is capsaicin, and same with essential oils, and we'll talk more about that too. Vitamin D, the last doctor did talk about that as well. I will say that I do have a caution with vitamin D. You can be too high. It is fat soluble, and we do have some research out there that says if you get on the far end of the spectrum over 80 nanograms per mil, it can cause, it has an association to cause cancer. So just caution, don't go too high. It's not one of those, the more the better. But it is important to actually be, within normal range for that. And there is an association for scleroderma patients and other patients with inflammatory type conditions to be low on vitamin D. I think more will come out about that too. But generally, sun exposure is one of the better ways to control that, to actually get the appropriate amount of vitamin D and in the right doses. But I know that we should avoid the sun and limit that. So 15 minutes 3 times a week is usually good. Yes?
So I'm sorry, when you said 80, you're saying that the goal there, 40 to 60, that going over 80 is not good. So how often do you get tested to know where you are?
So if your vitamin D dose is stable, then once a year or once every 2 years usually is good, unless your pain changes significantly. So if pain changes significantly or you've changed your dose dramatically, then yeah, I would say get it tested sooner. But usually after 3 months of supplementation, I test again. And just a side note, there are 2 different tests. There's an active test and a storage test. The only ones that like my system will do for cost reasons is storage. I keep forgetting the video's on. So storage would be, that's the only one they run, but there is an active test too. So if somebody's taking 50,000 units a week and they've been doing that for a long time, I will run an active and a storage on my patients to make sure they're both within therapeutic range. If they're too high, if either one or the other is too high, I personally think the risk is too high to continue the supplementation. And then the other question for you is, if the supplementation didn't help you at all, like there was 0 changes before you took a 50,000 a week and then after, do the 12 weeks and drop back off of it and maybe go on like 1 or 2,000 like he recommended. Okay? Medication considerations, sometimes we just have to start over in pain management. It's a combination of meds. It really is like that toolbox. It really is like a science where you pick one med and another med and ooh, that one didn't match up very well. Take that med and take another med and maybe add a third med to it. Again, I would prefer no meds, and we're getting there, but only change one at a time so that you know what the heck just happened. Don't do this whole 3, 4, 5 meds and from there. And then always look at the side effects. So use the side effects as benefits. If it causes sedation, use it at bedtime. And then there is genetic differences too. If some of these drugs, if you've had side effects, you may have a genetic variation that makes it to where you can't actually metabolize those drugs. So that is something that you would have to watch out for. And some of those drugs include like amitriptyline, hydrocodone, ibuprofen, meloxicam, oxycodone, fentanyl, just to name a few. And then allergies to medications, just to kind of give you an idea, allergies to medication, the true allergy is anaphylaxis. If you have itching to like the opioids, that's perfectly, that's a side effect of the drug. That's gonna happen. Whether you feel it or not, that's kind of based on your body, but it's gonna happen. And so the ones I'm concerned about are hives and facial swelling, because I don't know what's gonna happen the second time. But usually intolerances are not allergies. So be cautious when you put a bunch of allergies on your list. You might want to say that some are intolerances, that you just don't prefer that drug, because some drugs are related, and when you're in the hospital and if you're unconscious, as a hospital pharmacist in the past, we look at each other and going, what's the worser of two evils? Because you're not awake enough to tell us exactly what happened. So try and give them as much detail as possible as to what happened. There are a bunch of interventions as well. Epidurals, they can burn, radiofrequency ablations are where they burn the nerves, steroid injections. I can go through a million list of these for pain management. A pain management clinic will do these. Steroids always have a side effect, as we all know, and you can only have so many in a year. But sometimes they're longer term fixes, sometimes they're not. So that's where we get into the complementary medicine. So, you know, when I say complementary medicine, the goal really is blending all aspects of healthcare. Eastern, Western, functional, all the above. I just want to look at why is this happening and what can we do to fix it. So the only thing I did not include on this list is Chinese medicine, and we'll go through a lot of these. The colleague that was on my list, I love her. These are her slides, so I'm going to trip through them the best that I can. So essential oils for pain. I do have experience with essential oils. She knew the science a little bit better than I did, but just a big disclaimer. I am not saying that we need to ingest large amounts. I'm not saying it's used to diagnose, treat, or cure any conditions. They can just be a way to help reduce pain. Always talk to your doctor for anything. Go ahead.
With essential oils, after my mom got her surgery, she actually got double lung transplant last year. And as I was just in the ICU trying to see how I could be helpful and give her massages, etc., that's one of the things that I asked about natural oils, and also probably has a little diffuser.
Mm-hmm.
And doctors, they were against it. And I just tried to follow what they said. They wanted to make cool, not me. So, but based on my PhD on Google, as I mentioned, a couple of people I chat with today on research, there's a lot of people with different conditions that advocate to natural alternatives.
Yeah, so we still have to look at essential oils. Essential oils still work on similar receptors as drugs. And there's a slide on that one too in just a second. So the concern is for that one, a diffuser and a new lungs. They're going to do everything in their powers to protect those lungs, which makes sense, right? So in the grand scheme of things, if it's a risk of infection, because whatever is in that water is now vaporized, so it's not purely sterile water, the machine isn't sterile, and it depends on where the oils came from. If they're not pure oils, and a lot of the oils that are out there now with this whole essential oil boom, they're not pure. And so that's
one of the things that they mentioned. So, but for me, just a thought, because I started kind of doing research and how do you get the best oils, etc. So even just to keep her like massage in her arms and hands. So
yeah. If it's topical, I'm less concerned. Okay. It's essential oils are smaller molecules, so they do absorb better, but they absorb into the skin. In order for them to get all the way down to the bloodstream is much harder. And how much actually gets into the bloodstream is limited, generally speaking. If there is a concern with that, you can use it as more like on a cloth and have it like next to her, not necessarily like have her sniff it. So that way it's more of in the air type thing to keep it as safe as humanly possible. So, I mean, there's a lot of different tricks to do with it, but I look at it as if you are if you are ingesting it, it is still a drug, okay? So you can do too much of this stuff. And yes, there are studies saying that it is beneficial. And my colleague, I love her dearly, and she will probably kill me for saying half of what I'm saying because she is very pro-oils. I am cautious, okay? So they do work via the olfactory nerve with the limbic system. Topical, they do have some systemic effects, but most of it is superficial. And then internals, we'll talk about a slide on that one too. So very much like cannabis, okay, it's a terpene. Some of these oils are terpenes, just like medical cannabis. So that's why I'm saying it's still a drug, no matter which way we cut it. So she talks about this essential oil chemistry wheels. This is where each one works. Let's see if I can figure out what she's talking about here. And no, I can't, but I included the slides. I love you, Mary. Okay, moving on. More oils and where they work and how they work. It is interesting here to see around the wheel. It says stabilizing and soothing. I like that. That's the reason I included them. Okay, so the big thing on how aromatherapy works, using the diffusers and so on and so forth, is it really is to encourage relaxation and to decrease the perception of pain. So bring down that central nervous system. Like I said, duloxetine or Cymbalta does, it kind of does that, just with oils. So, and generally speaking, if there's no other issues with lungs, then it's generally safe. But like I said, usually I would prefer it to be more topical at that point or on a cloth near them. Deep relaxation with massage, surprise, and essential oils affect neurotransmitters and their receptor sites in the brain. So we're not even going through that. I love you, Mary. Okay, pain. So the pain blends that does have research to them. So there's more research coming out saying that these are effective. And in the world of pain management, if it's not going to hurt you, which again, talk to your doctors about that one. And again, they're on the far end of the spectrum as far as they're going to protect you. But if everything else is stable, generally speaking, these are okay. Of course, talk to them. So soothing blend, and then lavender. There's a lot to be said about lavender and how it works with sodium and calcium channels to help decrease pain. Black pepper and frankincense are anti-inflammatories, and same with peppermint. So I have made herbal blends for certain people, and no, I don't do that for a living, but that have been helpful for family members. So essential oils can be very effective if used topically, and internally, again, you can get too much. I have been told that they are effective internally as well. I am still nervous. The only one I will do internally is turmeric. And turmeric is an anti-inflammatory. That's also available as a tablet. I don't know how it's not in here. It might be in here later. But at any rate, turmeric is also another option that's used in a lot of Indian food as well. But it can cause acid reflux. Okay, so bergamot is another one. I could be saying that wrong. I don't know. Works for pain and also hyperalgesia, so that sensitivity of everything hurts when you just touch it, or if a sheet hurts, it's a way to help decrease that. So, and then peppermint is also good for GI distress. Here's all of the studies associated with that and the safety precautions with each oil. So for bergamot, avoiding sun exposure for 12 hours. And then certain medications, so it can increase like ketamine and methadone. So these are all important things to know if you're interested in any one of these oils, especially if taken internally. So medications compared to essential oils, like I said, they do work on similar receptors. So like lavender works on the same receptor as lidocaine. So for me, it's still something that we need to consider, that can it be effective? Yes. But it is something that we need to do with caution and use topically so that we're not getting as much systemic absorption. And then like anti-inflammatories effects, we talked about frankincense, and there's also Roman chamomile. And then CB2 receptors, there is some thought that copaiba It can be effective for that, and a lot of my patients have said copaiba works, which is an essential oil similar to cannabis, especially topically. I have not tried it internally on my patients. And then, so exercise and yoga, and when you get into all this other care that I think is very important, we're going to look at, with exercise and yoga, yes, we want to move. Movement helps pain, but ask yourself, is this safe for my body, and will I be okay later? So that's always important questions to ask yourself as you go along, and then you stay at the edge of that for a while. You keep your breath as calm as possible. You keep your body tension low, and then keep monitoring your pain and keep asking yourself, is this safe for me? And don't ignore it, but also don't pay too much attention to the pain so that, or too much attention to the actual pain that you're feeling. Keep that fine balance between the two, okay? Pain is a moving target, so practice is necessary on this one. But it is very, very effective for pain control. And then daily pain care planning. What's your plan for success? Today, make these small, minimal things for your breaks, and making sure that you take breaks in between. And how many times are you going to take breaks? Are you going to do 5 minutes and then take, an hour break? Just do small things. You don't need to run a marathon tomorrow. And so how will you calm your nervous system? So that's going to be very important too, and we'll talk about some of that as well. And then how many times a day? I'll tell you. My goal is 5 minutes 3 times a day. I am failing miserably. But I am doing well at 1 minute 3 times a day. See, I'm getting somewhere, right? It's all about being human. Okay, and then challenge yourself, of course. So breathing, I will say, coming from the Western world and being a patient, I'm like, that's not going to work. You're out of your mind. Well, in all reality, I will tell you, my colleague Mary did a pain care yoga thing, and I was her patient, and it was 3 days of deep breathing and relaxation and yoga and a lot of class, but I will tell you, after those, day 2 and day 3, I had the least amount of pain I ever had. Deep breathing 5 minutes 3 times a day. So you'd think it'd be more important to me at this point. But it really did work. So I have some techniques for you that can help with the deep breathing. So 3 compartment breathing, just going through these real quick since I still have a lot of slides. But 3 compartment breathing, start at the belly, slowly breathe into the chest, and then breathe into, I call it the shoulders, because I don't know about you, but most of the time I can't get it up here. And so the more you calm down, the more you relax, the more you can get the breath all the way up here, which is great for your lungs as well. But it really is a calming technique to help bring down that central nervous system without using duloxetine or potentially avoiding adding another drug. And then always taking deep breaths, saying longer, smoother, softer. And then there's another technique, and there's names to these, but I don't know them, where you have a color in one hand in your mind, and as you breathe in, the color goes up your arm, up this nostril, and then as you breathe out, it goes out to the other hand, and then breathe in, up through this nostril, and out and through this hand. It really is quite calming. And then there's Ujjayi, which I'm not even going to go through that. That'll take, a long time. But then the other thing is a scan, a body scan. So you start at your toes, and you can even start at one toe and then work your way up, going through each body part, piece by piece, and then going back around through to your head and then back down the other leg. I will tell you, that takes about 5 minutes. There are some websites to help for the people who fail miserably. Breathe to Relax and Tactical Breather are all very helpful for diaphragmatic breathing. And then stopbreathethink.org is another one. And then mindfulness and meditation, they all kind of go together after a while, but really we're just trying to decrease the central nervous system. Am I saying that you're going to be a yogi on the top of a mountain by the time you're done with this app? No. Am I trying to just decrease your central nervous system? Yes. So Cleveland Clinic Stress Free Now has a good one, Headspace, Calm. The one that's not on there that is free is Insight Timer, which is INSIGHT Timer, which I think is very helpful. But there are a bunch of other ones here as well. And then, so the mind-body approach really is all about stress management, different distraction techniques, biofeedback, and coming up with behavioral modifications, positive affirmations. Don't be too hard on yourself. You're great exactly the way that you are. You can only get better from here. So the pressure doesn't need to be there. Take baby steps, you'll get there. There's biofeedback, there's hypnotherapy, there's music therapy, there's cognitive behavioral therapy, which actually is really cool because before you had to go see a provider for that, and there were few providers. Now there's those 3 apps, and those are specifically for sleep, but they actually go through the whole cognitive behavioral therapy in an app. Very cool. Okay, nutrition. They talked about the FODMAP diet already. Do we know that one? We got that one, right? FODMAP, yes, okay. Avoid inflammatory foods, sugar, dairy, gluten, fried foods, yes, everything that is good. I can't do this yet. I'm just going to be straight with you. I pick one thing, and I say, I eat a lot of pasta. Okay, I'll change it to gluten-free. Okay, once I make that change, I say, okay, I'll make another small change. But you know what? I tried this whole, radical diet thing, and I failed. So I'm done with that. I will do one small thing and work on. Okay, comprehensive self-management websites. These are all very recommended for chronic pain. So anything else you ever want to know more about chronic pain, here's your 2 websites. Very cool, very intriguing. There are energy-based healings as well. So Biofield is working with your energy. Qigong is working with posture and movement and mindfulness and meditation all into one. I don't do that. Again, it's on my list. Reiki is the energy, passing one energy to another to help heal. So just remember, where attention goes, energy follows. If you are always thinking about that knee pain that's driving you insane, your pain is going to get worse and worse. So distract the attention a different way. Okay, manipulative and body-based. So chiropractor, osteopathic medicine, deep tissue massage. There is also a Thai massage. All can be very helpful. So basically, myofascia, medicine does nothing with myofascia, just being very straight with you. None of my drugs work on myofascia. So when I talk about myofascia, you have skin, you have muscle, you have bone, and then there's everything else in between. Remember how we said everything in medicine, if we didn't know about it, it doesn't exist and it doesn't do anything? And there's now news, shocking, news that says myofascia, the new organ. Okay, no, it's not new. We're just figuring out more of what it does, but it does communicate. There are little vesicles that actually go through your myofascia to communicate. We don't know what's in the vesicles yet, but we do know that it's very important. So if you have a knot, a tissue band, so if you reach around and you're like, yeah, it hurts right here, that's probably a trigger point of some sort. Manual therapy helps with that. So I do have some tools that I'll show you here in just a minute. But heat, ice, acupuncture, there is a special technique called the fascial distortion model. If you want more information on it, it is quite helpful to decrease kind of the knots and tensions, but you'd have to have a provider do that, and I'd have to look in your area. So the myofascial tools, 2 of the tools, a Theracane. Does anybody have a Theracane? Sadness. Okay, woo. Okay, a Theracane. So basically, it has a little knob on it, and it's a handle. See the handle? And so basically, you put it on the area of the knot, and you kind of rock it around to what feels best, and then you just hold it there. So you are doing your own pressure point release. You're doing your own trigger point release. That's for when I move and I can't find a new provider, and it takes me a long time. And then the jackknobber is another way to do that. Each knob on that is a different size. And the bigger it is, it's for the bigger knots, but a different size is going to work for different knots that you have or different tissue bands. And so just putting pressure on it, as long as you can last, it helps break up that myofascia. So functional medicine, big hot topic. Anybody heard of functional medicine? Woo! Misty is doing her job. Shout out to Misty Rushing. Okay, determining root causes of diseases. So is it a deficiency in a vitamin or a mineral? Is it an interaction with the environment? Is it gastrointestinal issues? Is it endocrine or immune? Is it what's going on? And they're trying to find the root cause to actually fix it. Kind of cool, but to blend the two is really difficult. But I will tell you, I do have a provider in my system that blends Western medicine with functional medicine. So they are coming out. So kind of keep an eye out for that. Myofascial pain, just real quick, the only thing that really works is to work it out. You can use anti-inflammatories to help decrease that, or lidocaine patches. Muscle relaxants, as we noticed, sometimes help short term. And then we talked about the other options, so Cymbalta being another one, and potentially tramadol. Fibromyalgia guidelines. Honestly, fibromyalgia guidelines are get moving. I know that's horrible, and when you're in pain, that's the last thing you want to hear, and I know this. So getting into a way to decrease that central nervous system, do myofascial release, consider duloxetine because that is one of the better ones, and usually duloxetine plus Lyrica or gabapentin are the best for those. But opioids are not preferred because they do tend to make it worse. And avoid benzodiazepines for sleep. Geriatric pain, again, those are the options for geriatric pain. Avoid the things that cause heavy sedation, and including cyclobenzaprine and tricyclic antidepressants like nortriptyline. End-stage renal disease, here are some options for you. There is some question. Talk to your nephrologist. They're very well informed on that. Liver dysfunction, avoid anti-inflammatories, avoid high-dose Tylenol, but you can take gabapentin and Lyrica and then tricyclic antidepressants in low doses. So with the pain conversation, and most important, be able to tell your doctor the pain, what's going on exactly, where does it hurt, what does it feel like, how long does it last, what happens beforehand, ask for recommendations. Think about the 4 wheels. What other options do I have in this system? And keep asking. Everybody has a little pearl that they're going to give you. It may only be the smallest pearl ever known to man, and believe me, I have a lot of these in my toolbox over the last 20 years, but they're still there and I can use them. Always come back with concerns or questions. Develop a backup plan. What's going to happen when your pain is worse? Develop that toolbox. Come up with different options. Ask all your medication questions, side effects, long-term effects, will they lose their effectiveness, drug interactions, what to monitor, so on and so forth. Keep that conversation going with both your pharmacist and your physician. Communication tips, you are your expert. Keep a journal if you can. Come with questions. Be prepared. That 15 minutes goes quick. And then you don't normally get an hour like you do with me. And then take someone with you is the other recommendation that I have for you. And then ultimately patient empowerment, drive your car, do your journal, bullet journaling, document what you've learned, learn the different tools, figure out what you can do, celebrate successes, and learn something new from every provider. Here's the paintoolkit.org. Very cool. If you're really good with pain management and anxiety, you will know all 12 tools very well. And then, again, the goals of treatment: increase quality of life, increase level of activity, and decrease severity of pain. But make small goals that you can obtain, like walk to the mailbox. I mean, really, it sounds that simple, but it really is. I'm going to get out of bed for 10 minutes today and sit in my chair, just something. But keep it a goal and keep tracking it. So in conclusion, pain is very complex. Think outside of the box. Keep your toolbox. Everyone's completely different. Treat pain at the source where you can. There are many, many, many options. If nothing else I've told you today in this 83 slides that I have, it's many options available. So we're looking at effective treatments for you. You figure out what works, develop those tools, master them, use them in different combinations. Keep educating yourself and take an active role. Don't let pain drive your car. Keep it in the trunk and have a whole minivan of people if you need to help you navigate that road. Any questions?